Okay, so immune disorders relevant to psychiatry are becoming important, especially for your exams. So here we're going to talk about anti-NMDAR encephalitis. This is a condition that is present in a small number of first episode psychosis patients. It's an autoimmune condition. You produce antibodies against your own NMDA receptors, which are glutamatergic receptors. So you're going to develop a lot of symptoms that are similar to blocking NMDA pharmacologically, like using ketamine or developing schizophrenia. So how do these patients present? They usually present with a prodrome, which could last for a week. Patients have subfebrile temperature, vomiting, headache, anxiety, and mood changes, quite non-specific. Then they develop acute psychosis, generally delusions, hallucinations, aggression, mania, as well as sleep disturbances. Sleep disturbances are often a part and parcel of anti-NMDAR encephalitis. Patients then may present with NMS-like features, a neuroleptic malignant syndrome-like features, and this could last for weeks to months. Patients develop neurological problems like hypertonicity, dystonia, dyskinesia, autonomic dysfunction, breathing difficulties like hypoventilation, and they may also have altered consciousness. Some patients go on to develop cognitive deficits, which might last for many years, just like schizophrenia in that sense, executive dysfunction, disinhibition, impulsivity, as well as cognitive deficits. So this is a cycle that you see in patients with anti-NMDAR encephalitis. So what are the red flags for us to suspect that a patient has autoimmune encephalitis when they present with first episode psychosis? Number one, if there is any stigma of infectious prodrome, we need to suspect encephalitis. If patients with psychosis complain about new onset headaches, or if they have decreased consciousness and episodes of seizures, it becomes important to think of them as red flags. This condition, autoimmune encephalitis, is often seen in young females with no prior psychiatric history. Also, if you see a patient who has never been exposed to antipsychotics, but having NMS and movement disorder at presentation, at the time of presentation with psychosis, they have autonomic disturbances, fluctuant catatonia. These things should make you worry about autoimmune encephalitis. Patients with autoimmune encephalitis also have speech dysfunction, much more prominent than your conventional case of schizophrenia. They may have aphasia, mutism, and dysarthria. And most encephalitis are acute in onset, and they are rapidly worsening conditions. Often patients might have some peripheral tumors in their body. They may have an autoimmune predisposition. They may have paraneoplastic syndrome secondary to these tumors. In some series of cases with autoimmune encephalitis, ovarian teratomas were seen in around 50% of patients. So it's very important to watch out for those. Patients may also have disproportionate cognitive dysfunction. We know there is some degree of cognitive dysfunction that happens with schizophrenia, but in autoimmune encephalitis, they might have much more cognitive dysfunction. These are all red flags for autoimmune encephalitis. How do you investigate a patient for whom you suspect autoimmune encephalitis? CSF examination is a key element. You might see pleocytosis. You might also find oligoclonal bands or increased IgG index. The clinching feature is IgG anti-neuronal antibodies. Presence of IgG anti-neuronal antibodies in the CSF is an important diagnostic feature. If you do a T2 weighted FLAIR MRI, you might find bilateral brain abnormalities, mostly restricted to the medial temporal lobe, which is the site of infection, site of immune activity here. You might also have EEG changes, spike wave activity similar to seizures, rhythmic slowing. You might also see focal changes or extreme delta brush, which is a feature of many encephalitic syndromes. You may have anti-neuronal antibodies in the serum. You can detect that by cell-based assays. If you do FDG PET, glucose uptake PET, you might also find medial temporal hypermetabolism, increased metabolic activity in the medial temporal lobe. There's an unexplained hyponatremia, reduced sodium that you often see in these patients.